Hello, this is Cameron Sabet, and welcome to Cutting to the Case. I'm here today with Dr. Matt Starr. He's an associate professor of ophthalmology at Mayo Clinic and serves as residency program director for the Department of Ophthalmology in Rochester, Minnesota. A vitreoretinal surgeon, Dr. Starr completed residency and internship at Mayo Clinic and a fellowship in vitreoretinal surgery at Wills Eye Hospital. His clinical and research interests center on optimizing outcomes following vitreoretinal surgery and uh, the management of dislocated intraocular lenses and advancing therapy for age-related macular degeneration. He's the principal investigator of multiple clinical trials evaluating novel treatments for both exudative and non-exudative macular degeneration. Dr. Starr has also pioneered opioid optimization strategies following ophthalmic surgeries and applies lean thinking approaches to patient safety and quality improvement. He currently serves as an editor of the ocular trauma section for EyeWiki, an assistant editor for Retina cases and brief reports, editor for the Retina Journal podcast, associated editor for the Retina Roundup, and associate editor for Osley Retina. Thank you very much for joining us today.
Thanks, Cameron. I appreciate that kind introduction.
Yes, of course. And I wanted to start out this interview with a bit on your leadership because it's truly astounding how many things you've been involved with, both in and outside the clinic. So your leadership as program director really shapes the trajectory of Mayo trained ophthalmologists. How do you approach mentoring residents in such a rigorous environment?
No, thanks. Yeah, great question. I mean, Mayo is Mayo. I mean, I'm here, and I mean, I love it. And but to be honest, there's a good, program in place. I've been doing this for 3 months now, and in reality, I had jumped on something that was moving pretty well. It's like, hitting a home run, starting at third base kind of thing. It's just like there was already a good thing going, and I'm here just to kind of keep it moving forward. And
Mhm.
that's kind of, my philosophy is, don't mess up a good thing. And, I'm really happy with how the program is and, the ophthalmologist that we produce and the training that we give our residents. And my goal right now as PD is just to continue to push our residents to be the best versions of themselves and really kind of make them um, get put them in the essentially the spots where I think they will flourish and do best.
Yes, yes. And you've really kind of inherited a well-oiled machine. And so,
Yeah,
yeah, just to help it spin even faster and, move even more quality output in terms of residents um and
yeah. That's what's kind of unique to Mayo is Mayo every time there is a leadership position, whether it's a chair of a department, program director of the residency program, the administrator, the business, the practice chair, all those positions cycle every 8 years. And I think that's kind of nice that it allows for kind of fresh input on a kind of a regular basis. And so not one person's going to kind of dominate the department for 20, 30 years. And that's unique to Mayo. You don't see that a lot of places.
Mhm.
And I think Andy Barkmeyer, who was doing it 10 years before me, and then Andrea Tooley, who was doing it for 2 years before she moved back to closer to family. I think that's what, for me, I inherited something that we knew was going to be, probably mine at some point. And, just happy to kind of, take it and continue the great training that we give our residents.
Yes, and it really meshes well with the broader philosophy of research, education, patient care, the holy trinity of Mayo Clinic, really pushing that forward, having that fresh input all the time, not letting one dominate the crowd space.
Yep.
Yeah, of course, of course. And along the lines of research as well, vitreoretinal surgery, which is what you do, has seen dramatic advances in recent decades. I'm curious, which innovations have most changed your practice?
No, I think that's another nice question. I think, I mean, honestly, us as surgeons, vitrectomy is something that we can't live without these days. I think for me, what I do, most commonly are suture lens cases. That's probably like 40 to 50% of my practice, and so I selfishly I like to see all the advances that we've been making as a field, towards, those surgeries, whether it's, the innovation of Gore-Tex, Dr. Yamane's Yamane technique. But to be honest, in retina, just in general, like OCT, I mean, hands down, like that's the craziest thing that's ever been done in ophthalmology. And just how that's changed how we practice as ophthalmologists is just completely um, unrealistic. I mean, you just don't see something like that that dictates how we practice. I couldn't run my clinic without that machine, and I think that's an easy answer when you ask for retina.
Mhm.
I'm really excited for all the things that are coming in the future. Now how we're pushing with AI and home OCT and long-term anti-VEGF agents, and then as a surgeon, I love to see how we can turn wet AMD into a surgical problem, and so those are all kind of the fun things.
Turning wet AMD into a surgical problem. That's really fascinating. And on the topic of macula too, you've studied the outcomes of macular hole repair and other things as well, like retinal detachment surgery and epiretinal membrane removal. What gaps in the evidence remain the most pressing for you?
I mean, I think that I mean, I'll be a kind of a fanboy, and Rajiv Mooney is a huge person in the field of vitreoretinal surgery, and I loved how he talks about we do a really good job with our anatomic outcomes, but how can we think differently? Retina, it's always been, retina attached or not attached, membrane removed or not removed, but like, what can we do to make the vision better? Like, our patients still will come after like a retinal detachment repair and they're 20/20, but they're a little bit upset because they notice some metamorphopsia or some way, some sort of scotoma in their vision. And I think, how do we keep pushing the field towards better vision outcomes? And that's what I've been focusing on with, secondary lens work and things like that is let's, I know we're getting the lens in a better position. We're putting them from, count fingers and motion vision to, reliable vision, but like, how can we make that even better?
Yes, again, ophthalmology is almost like the well-oiled machine of the residency that you took over, and it's how to perfect and add those final tweaks
Yeah,
to
exactly.
really. Yes, yes. So, your work also on opioid optimization after ophthalmic surgery is pioneering. I was curious what lessons other surgical fields can draw from your approach.
And that's an interesting question because I feel like we're drawing from other surgical specialties. We're behind the eight wheel there. I think eight ball. Other specialties who prescribe a lot of opioids are way ahead of ophthalmology. I think in terms of how to appropriately prescribe them. I think that's because they prescribe them so often, and they're learning how to appropriately prescribe them. As ophthalmologists, we don't prescribe them a lot, and I think that's where we have to be cognizant of what we're doing. And I think it just wasn't done in ophthalmology. And I was happy to kind of spearhead a lot of that work. Obviously, it's like, I do what we do here at Mayo, but, Maria Woodward in Michigan, she's doing a lot of awesome stuff. Cindy Young at Harvard, one of my mentors, Yoshi Yonakawa at Wills, like, I mean, they're just all kind of trying to push the field forward in terms of opioid optimization. Not to dismiss, patient pain following surgery, but how do we adequately address those problems in a safe manner? I think people don't realize how dangerous some of these medications can be, and just to kind of shed some light into appropriate practices, appropriate prescription practices for these medications. That's something we're trying to continue to get out there. But even more than that is do we really need to be doing it for certain procedures? In my opinion, cataract surgery, that's one that should be a never kind of prescription of it, but oculoplastics, cornea, those are some painful surgeries, and I think that's where you have to be just judicious in how you do that. Retina doesn't have a lot, in my opinion, that are super painful. A buckle, maybe not. But to be honest, I mean, I haven't prescribed an opioid, since I've been in practice.
Yes, yes. Because I mean, ophthalmology does get a reputation for being very clean in terms of their surgeries. And so, the thought of opioids may be surprising to outsiders, but it's
Yeah,
critical, like with oculoplastics, orbital
yeah,
fracture.
cornea is a big one, just because of how painful, epidural is, and they're, doing LASIK PRK. They have a, almost like a reputation to upheld of like a really smooth, I mean, that's like essentially it's like cosmetic surgery for the eye. you want you want the patient to have like a seamless procedure. You want no pain, nothing. And I think that, I mean, it is a painful, I mean, having an epi defect is awful. I mean, it's really uncomfortable. And so, I think they have, a tough time to kind of battle that, line of, providing something for the patient, um, from just almost like a purely cosmetic standpoint to make them, super comfortable for that procedure.
Yes, yes. And so, bringing this idea of quality improvement and patient safety, kind of to the innovation side of things, what's been your experience with balancing those clinical advances with the realities of patient safety and quality improvement?
Yeah, no, I mean, I got started in QI and patient safety, when I was like, an undergrad student. I had a great mentor, who was an interventional neuroradiologist at WashU in St. Louis, and he instilled to me, like this interesting kind of ethos about patient safety. It it was really transformative for me, and I think how do we continue to strive to make medicine better but also at the same time put patient needs first. There's a lot of principles in that kind of thinking that we can carry out through all fields of medicine. I mean, he was a neurointerventional radiologist, pediatric, even further scope down, interventional neuroradiologist, and he's instilling these principles for me as a retina surgeon. So we're crossing fields, pretty dramatically,
Hmm.
and really, it's just there's a lot of different things, and for me, when I teach the residents and in my practice, I really try to push to something called a just culture, and I think that that is the easiest thing to kind of understand is just it's not a hierarchical field of medicine. I want them to speak up when they feel something's not right or something's wrong. It's utilizing timeouts. It's utilizing the standard protocol, standard procedures, and that kind of stuff.
Hmm.
Um, and how do we continue to integrate that into ophthalmology? Ophthalmology is somewhere where you have a lot of opportunity for standard protocols and procedures and lean thinking because we're super busy. Probably one of the busiest fields in all of medicine, especially retina. I mean, retina, we're seeing 100 patients a day sometimes. And it's just, that's where errors happen when you have, that many opportunities,
Hmm.
one, and then you're working that fast. So just how can we put, the needs of the patient first and, thinking of patient safety at all times.
Yes, yes. And those conversations about patient safety, as you very well know, kind of expand into the national conversations as well. In your view, what role should ophthalmologists, being the busiest specialists in all of medicine, play in shaping national conversations about healthcare delivery and surgical innovation?
Yeah, no, I think that that's interesting because we as ophthalmologists are not, we're not. I mean, I'm so far removed from regular medicine as a retina specialist. I mean, it's pretty wild, and so I think that we have to remain, you know, active. We have to remain active in advocacy, active in kind of leadership groups, and make our kind of opinions heard. For me, it starts at Mayo, just joining different committees, making ophthalmology's kind of print heard, and you know making sure that we are still kind of well represented in larger national groups. But to that point, I mean, I think that we have to be you know also aware of the other you know medical groups and their needs, because we're very different. I think that ophthalmology as a field offers opportunities for lean practice, especially on a private practice kind of side, lean business thinking. But how we also, as other fields advance towards trying to streamline patients, they can take our examples of how we run busy practices, busy injection clinics, cataract surgeries with implants, and how we have a lot of safety checks in place for implants and things like that. That's where we can be kind of advocates because we do those really well. Unfortunately, in medicine, the biggest offender in terms of surgical errors is wrong implants. Ophthalmology, we implant a ton of cataracts, but there's also orthopedics. Orthopedics is a huge field, and joint implants, knee implants, hip. Those are also a frequent offender, and I think that's where we have to be good advocates and good examples of how we can appropriately show how well we do in terms of our implant technology and our implant process.
Yes, yes. And I also wanted to discuss very um, kind of connected to robotics and implants. How do you think about integrating new technologies like artificial intelligence into vitreoretinal surgery and potentially implants?
That's interesting. I mean, I think that AI is here. Um, it's not going to replace surgeons. It can't do that, but it really should be there to enhance our field. You know, here at Mayo, we're doing a lot of really interesting things in terms of analyzing OCTs and analyzing retinal thickness and retinal fluid status using AI. But in reality, it's going to really it should add advance our field. As long as there's a lot of good teaching models, and everybody's at this stage is pretty interested in making good algorithms, good good language, large language models to help us practice. And I think that as we get more in tune and more aware of these models, it'll be really interesting to kind of see where they take us. But I mean, it's here. It's going to be the future. I mean, it's not. I mean, it's you're here now. The future is now. In terms of robotics, that's super interesting. I think that that's something that's not talked a lot about in retina surgery, but it's definitely happening. Um, a lot of good data, a lot of good publications on robotics improving tremor. Um, I myself think that I have like zero tremor, peeling a membrane, but even the best retina surgeon has some tremor, and it's zero, like in a robot. And does it affect outcomes? And we'll see, but it's pretty interesting to see kind of how they do that. I think where it's really taken off is in cataract surgery.
Mhm.
I think I think they just published their first report of I think the cataract coach himself, Uday Devgan, doing your robotic cataract, remote. I think that's pretty cool. Yeah, that's pretty neat. You can do a surgery, thousands of miles away from the patient, and that's been in the works for a while now. I've known about this robotic cataract surgery, but I think that was just became public, or public, uh, essentially publication or news article, within the past like month. That's how you make care equitable. You know, I think that again, tying it back into patient safety is how do we make care equitable? How do we deliver the best care to all patients? We utilize the tools that are at our fingertips, and it, if we can provide care to more people, safely with that, advent of robotics, that's a pretty awesome tool. I think there's a lot of questions, a lot of concerns about robotics, but if they're going to allow us to provide high level care to a broader number of patients, I mean, we have to really, kind of take that head on and not fight it, but embrace it.
Yes, yes. And speaking of embracing the future as well, I wanted to know, as PI, principal investigator of trials for age-related macular degeneration, how do you see new therapies reshaping patient care over the next decade? I recall you wanting to pursue a wet macular degeneration, make that surgical, but how else? What
Yeah,
else?
no, I think that's happening with the current, gene therapy trials. We're taking, you know, patients with wet AMD and doing, subretinal gene therapy delivery. We're also doing, suprachoroidal, drug delivery. And I think, that's how we, reshape, AMD care. I think right now, and, at least from a retina standpoint in diabetic patients, we have a lot of different options, a lot of different tools. For AMD, it's awesome, wet AMD that we have anti-VEGF injections. That's been, again, in line with OCT. Like if we, I mean, I tell patients all the time that don't like injections that 20 years ago we weren't really doing these, and now we actually have an option to treat you. Um, but that's really all we have. It's been really cool to see the advancement of these kind of, we call them second generation drugs with faricimab, aflibercept HD. It's that's really neat. But how can we provide other things? I think as the tyrosine kinase inhibitors come to market, as the gene therapy products continue to develop, there's going to be options and kind of tag team approach where some patients may have gene therapy. Maybe they don't need a lot of injections anymore, but you can supplement on an annual or biannual basis after performing that kind of surgery. Or you have a TKI with an implant, with a port delivery system. I think we're providing long term better care, less office visits, with better vision overall. I think that we know that half our patients do really well, but how can we target the other half who are really difficult to treat? And that's where I think continuous drug delivery is going to be the best thing for some of those patients. Um, but yeah, it's really exciting in retina. I mean, that's why I went into retina when I was a med student 10 years ago, which is, I remember it was like 2014. I was a fourth year med student, graduated 2015. In 2014, like I had a plastic surgeon tell me like retina's wild, wild west, and it still is. And it's there's so many different things happening, and we continue to advance the field of retina. Um, it's truly an awesome time to be here, and especially for the residents and students. We want to um, continue to provide high level care and continue to advance the field. And I think with a lot of different things, we're providing really awesome surgical techniques, and we haven't even really touched on it, but gene therapy is going to really revolutionize how we take care of a lot of our retina patients.
Well, would you like to expound on that for our audience? I mean, that's an exciting point for a lot of medicine as well.
Yeah, you mean so? As you know, Luxturna was the first gene therapy approved in all of medicine. To treat you know those children, and the it's been a game changer.
Mhm.
Technically I'm Luxturna certified, but I'm not a pediatric retina surgeon. I like to give that to my partner, Dr. Scruggs, and I'm certified just so that she can do them. Because when you have a Luxturna site, you need two surgeons, and so it's a funny story. But essentially, I'm her backup in case something fails mid surgery, but that's never going to happen. But it's been a game changer. Those patients are blind, essentially functionally not moving around, and then they have the surgery and they're moving around, navigating difficult situations. So that happened almost 10 years ago now. And we're going to continue to find different genetic mutations to treat different diseases. There's so many different trials for inherited retinal degeneration. I am one. I didn't go into retina to do IRD. I didn't find it fun. I didn't find it interesting. But now it's honestly that's the new kid on the block. It's such an advancing field in terms of we can treat it now. There's potential that we can do something for these patients that once were just okay. You have this interesting kind of retina picture. You have this interesting genetic mutation, and potentially if you have the appropriate genetic mutation, we have a treatment for you, and that's awesome. And for me, as someone who doesn't do IRD, we're able to treat different diseases like AMD, diabetes, or retinal vein occlusions, and I think that it's really, it's going to I mean, it's here to stay. It's going to revolutionize, how we treat our patients. We'll see how some of these early, these, later phase studies kind of pan out in the next year or two. It's coming. We've got several, phase 2, phase 3 studies here at Mayo that have finished uh, recruitment. And that data, once they kind of get their year follow up, will be at the end of 2026. And so hopefully we start to see some of those results coming out, and again, approval by the FDA and in our hands to treat our patients.
Yeah, that's the bleeding edge of all of medicine, really. I remember, I think 2 years ago, I was speaking with Dr. Thaddeus Dryja at Mass Eye and Ear about this whole thing. He actually discovered, I believe, 16 different genes for retinitis pigmentosa and retinal degeneration. I believe he was part of the team that identified and cloned the retinoblastoma gene as well. So he was really foundational to that as well. And so it's amazing to see a lot of these kind of innovations coming out of these incredible places too.
No, yeah, I definitely hear you on that one. And that's what's also kind of tricky is when you have 16 mutations to the same phenotype.
Yes.
it's nice when you have, a single, that's why the RPU 165 is nice for Luxturna. I think that, um, when you find a disease that has, a common mutation,
Hmm.
and that's where these kind of push these things forward.
Yes, yes. And you were also mentioning all these slow release agents as well. I mean, I'm thinking like Ozurdex and all the ways that I've been speaking to people in other fields and they were considering using Ozurdex or like the slow release form of that in other kind of implants to do slow release in other areas of the body and using the same polymers. I believe like a PEG-PLA copolymer or something like that that they use to do a slow release chemical. So, I mean, really, ophthalmology is kind of bleeding into every field, and it's incredible. I think, as one ophthalmologist once told me, there's a quote from the Buddhists, I believe: "Look into a dewdrop, and you can see the whole universe." And that's really ophthalmology. It touches on, dermatology. It touches on infectious disease. It touches on genetics, and it's just this incredible surgical, just wild west.
Exactly. I think that's what's neat is you still, I mean, like I said before, I'm far removed from like medicine, but it still ties into, as you said, to everything. And I've got to be, well informed in terms of like infectious disease and rheumatology, especially for me. But yeah, that definitely a lot of different specialties will derive ocular findings.
Of course, of course. So I want to be respectful of your time. Just final question, kind of a very broad thing for our audience of trainees and medical students. If you had to distill your philosophy of leadership into a single principle for the next generation of physicians, what would it be?
No, that's tough. I think that right now when I tell my residents, and it's not like a necessary leadership style, but I want them to be the best versions of themselves. I want them to learn the best, and it's kind of something that was taught to me, as a retina surgeon is you've got to see and do all you can during training. And I think that's where it's like see all the quote was see all the patients you can, do all the surgeries you can, stay late. It's hard. Train ophthalmology residency is 4 years. If you do a fellowship, it's 1 or 2 years. But then that's it. You have no other opportunities to learn. You do CME and you've got conferences, but really you've got that kind of blanket of help, for just a few years. So really utilize it. And I tell them, I tell my trainees like, see as many patients as you can, do as many surgeries as you can. Come to my OR,
Hmm.
stay late with me, and that's when you're really going to learn from our patients because they, one that if you're there, you're likely going to be involved in their care. But not only that, you're going to learn, you're going to learn something from that encounter. And I think that's kind of my little pearl I try to drop to all of them. And that's not necessarily like a leadership style. I think it's just kind of like a life philosophy on how to succeed in ophthalmology and retina.
Yes, yes. Surgery is muscle memory. And, one of the previous people we had on this podcast was the director of development at C International, which was a nonprofit that sends ophthalmologists overseas to kind of get that volume in and start continue in their training and to incorporate a bit of service there too. So I've heard that from other ophthalmologists that, getting a lot of volume is really the name of the game.
Yeah, I mean, volume is one thing and have good teaching associated with it. But I think that if there's always a potential like patient encounter that you can be a part of, you ought to take advantage of that.
Of course, of course. Thank you so much for joining us today on Cutting to the Case. This is incredible.
Yeah, no, thanks for having me. I really appreciate the opportunity to chat with you.
Of course, of course. So this is Cameron Sabet, Cutting to the Case, and until next time, we're signing off.